This patient is a 48-year-old male with multiple risk factors for heart disease, including early positive family history, hypertension, and dyslipidemia with an LDL cholesterol of 146, who developed symptoms of dyspnea exertion and had nonspecific findings on a stress test with ongoing symptoms. He was referred for cardiac CT angiography to rule out possibly of obstructive coronary disease. Initially, we'll go to the MIP view with a 5mm thickness. I'm going to just scroll through the images to get the left main in view, which is seen here, nicely displayed. There's no evidence of obstructive plaque. There may be some mild non-calcified plaque in the inferior portion of left main, which does not appear to be significant. We'll now flip the heart into the foot or axial view and roll out the left anterior descending artery, which has some definite minimal to mild plaque that's eccentric in the proximal vessel with some speckled pattern there, maybe some early calcification, which does not appear to be obstructive. There's a takeoff of a medium-sized diagonal branch, and then the distal LAD, which extends out towards the apex of the heart and does not appear to have any high-grade lesions, anything significantly obstructive in the distal vessel, which can be followed all the way out. We're recentering the heart now, coming back to the takeoff of the left main, where we can see a large branching ramus intermedius branch, the upper limb of which may have some mild to moderate non-calcified plaque in the proximal segment. And then this larger branch, which extends towards the apex of the heart, has some moderately obstructive mixed density plaque, which is eccentric in nature, but likely not a high-grade obstruction in that area, but definite plaque there in that distal ramus branch. We'll now turn our attention to the circumflex. This extends under the left atrial appendage and is a relatively small vessel that does not give off a significant obtuse marginal branch to the lateral wall of the heart, and does not have any significant obstructive disease. The right corner is best visualized by going into the anterior view and then rotating the heart into essentially an LAO caudal view, which brings out the circumferential vessels of the heart. And here we can see the right coronary coming into view. And of note, there is some evidence of, again, some non-calcified and non-obstructive plaque, both inferior and superior segment of this proximal right coronary. The ostium appears to be free of significant disease. And the body of the right coronary, again, maybe some minimal non-calcified plaque in the midsection. And as we come around the bend here, we have a very nice looking vessel that extends out to the inferior wall of the heart. There is some mild to moderate non-obstructive, non-calcified plaque at the bifurcation of this posterior lateral branch and the takeoff of the posterior descending artery here. Other findings here, going back to the foot view, includes some atherosclerosis of the thoracic aorta, which is eccentric, occasionally some calcified segments here, but no evidence of aneurysmal disease, nor is there any dissection. Furthermore, there's a finding of a potential patent foraminal valley. Here's the intraatrial septum, and it looks like there may be some contrast going across here that might be better visualized in the MPR view. And again, looks like we have a small fossa ovalis segment here with perhaps some contrast exiting into the from the left atrium to the right atrium. So in summary, we appear to have some evidence of atherosclerosis in the coronary arteries in this patient with multiple risk factors, with some mild to minimal disease in the proximal LAD, some evidence of some potentially moderate mixed plaque in this distal portion of this ramus branch, as well as some plaque in the proximal portion of the right coronary, which is seen in this segment here, which again appears to be non-obstructive, as well as the non-calcified plaque seen in the distal right coronary at the bifurcation of the posterior lateral and posterior descending artery. There's atherosclerosis in the thoracic aorta, and there may also be a small patent foramen ovale.